Welcome to The Explainer. Today, we are getting into a fascinating organism, one that's really stepping out of the shadows and making us pay attention in the clinical lab. Corynebacterium pseudodiphtheriticum. For years, a lot of us might have just brushed it off, but believe me, that's all changing. And check this out. This quote from our source material absolutely nails it. It perfectly captures the whole story we're talking about today. This bug's journey from being dismissed as just another diphtheroid to being recognized as a pathogen we have to take seriously. Just a quick heads up, all the information we're about to cover was pulled together using a Gemini deep search. If you want to go down the rabbit hole yourself, you can find a full list of the primary sources in the linked notebook document. So here's our game plan. We're going to follow a really logical path, starting with why it's an emerging threat. Then we'll jump to the lab bench for identification, cover what it does to patients, tackle the challenges in treatment, and wrap up with infection control. First up, the emerging pathobiont. Let's dig into how our entire view of Corynebacterium pseudodiphtheriticum has been turned on its head. You know, it's not a new bug, but our ability to actually see it for what it is. That's new. And really, this organism is the poster child for what we call a pathobiont. Most of the time, it's just hanging out harmlessly in the upper respiratory tract. But you put it in the wrong host, under the wrong conditions, and it can cause some really serious trouble. So what caused this huge shift in thinking? Honestly, it pretty much all comes down to one piece of technology, MADTOF-MS, becoming standard in clinical labs. It finally gave us the accuracy to stop waving this thing off as a contaminant and see it for what it is, a genuine opportunistic pathogen. Okay, let's head over to the bench. We're going to look at how we can get a solid ID on this organism and, just as critical, how we can tell it apart from its other clinically important cousins. All right, so looking at it under the microscope, there are no real surprises. You're going to see those classic coroniform shapes, the gram-positive, club-shaped pleomorphic rods. And you'll see them in those telltale V-forms, palisades, and Chinese letters arrangements that just scream Corynebacterium. Now, this is where it gets interesting. Looking at the key biochemical tests, two things really jump out for Corynebacterium pseudodiphtheriticum, that rapid positive urease and the fact that it doesn't ferment carbohydrates. Those two clues are absolutely critical for separating it from fermenters like Corynebacterium diphtheriae or the notoriously multi-drug-resistant Corynebacterium striatum. But what about when you need a definitive molecular ID? Especially when you need to separate it from its nearly identical twin, Corynebacterium propinquum. Well, 16S RNA sequencing can actually get you into a bit of trouble because they're so similar. That is why sequencing the RPOB gene has really become the gold standard here. It has way more variation between species, which gives you the power you need for a confident, clear-cut ID. So we've nailed the ID on the bench. The next big question is, what is this thing actually doing to our patients? Well, the clinical picture is pretty broad, and it really, really depends on the host. Let's be clear, this isn't a bug that's going to take down a healthy person. It's an opportunist that picks on the vulnerable. We see it pop up most often in patients who already have underlying lung disease like COPD, people who are immunocompromised, and, very importantly, in patients with indwelling medical devices like prosthetic heart valves. And the infections it causes are, well, they're all over the place. Everything from pneumonia to infective endocarditis, but the one that really gets your attention, the one that can cause an exudative pharyngitis with a pseudomembrane that looks exactly like classical diphtheria, wow, that creates a huge diagnostic and public health scare right from the get-go. Okay, let's switch gears and talk about treatment. And this is where things can get really complicated, not just for the clinicians, but for us in the lab who are trying to support them. So looking at the general susceptibility patterns, the story is pretty clear. On one hand, you've got your beta-lactams and glycopeptides like vancomycin, and they look great, very high rates of susceptibility. But then you look at the other end of the spectrum, resistance to macrolides and clindamycin is incredibly common. So you definitely wouldn't want to use those for empiric therapy. And of course, to take a raw MIC value and turn it into a clinical interpretation, susceptible, intermediate, or resistant, we rely on official clinical breakpoints from groups like UCAST. So here it is, the big problem. As of early 2025, ECAST has 0 specific breakpoints for this organism. None. What does that mean for us in the lab? It means we can't just report S, I, or R. We have to report the raw MIC value, and that means a direct phone call with an infectious disease doc or a clinical pharmacist is pretty much essential to figure out the right treatment. So without those official breakpoints or even specific national guidelines from bodies like SWAB in the Netherlands, for example, what do? Well, clinicians are forced to rely on approaches from the medical literature, like what you see here. Treatment gets tailored to where the infection is, and crucially, to the specific MIC results for that particular isolate, with beta-lactams usually being the go-to choice if the bug is susceptible. And if you thought the data for adults was a little thin, well, for kids, it's even more of a gray area. The treatment principles are similar, but everything has to be carefully dosed by weight. Certain antibiotic classes, like fluoroquinolones, are generally off limits, and honestly, a consult with a pediatric IED specialist is pretty much mandatory. All right, last but not least, let's talk about infection prevention. How do we stop this from spreading in a hospital without causing a full-blown panic? Okay, this is probably the single most important takeaway for anyone in infection prevention and control. The rules for Corynebacterium pseudodiphtheriticum are fundamentally different and way less intense than the rules for toxigenic Corynebacterium diphtheriae. You do not need to trigger a massive public health response for this bug. The key, the absolute cornerstone, is just consistent use of standard precautions for every single patient. That means good hand hygiene and using your PPE correctly. If the patient has symptoms like a bad cough or a draining wound, then sure, you can add on droplet or contact precautions, but the basics are what will prevent spread in the hospital. So, after all of this, we're left with a really critical question for the future, right? Our diagnostic tools, like MALDI-TOF and sequencing, are getting so good that we're finding this organism all over the place. The real challenge now, for all of us, microbiologists and clinicians, is to get better at figuring out when it's just a harmless colonizer versus when it's a real pathogen that we actually need to treat. And that is the central challenge ahead. Hey, if you found this deep dive valuable, do us a favor and hit that like and subscribe button. And we'd seriously love to hear from you in the comments. Tell us about your lab's experiences with Corynebacterium pseudodiphtheriticum. Thanks for tuning in.